Hi everyone, my name is Caitlyn Caplette, and I'm currently doing my clinical rotation at Leominster Family Medical, a family primary care office. And today I'll be presenting a complex acute care case involving a 61-year-old female that we saw. She presented with rapidly progressing post-auricular pain and swelling that raised concern for mastoiditis or deep soft tissue infection. I chose this case because it highlights the importance of early recognition, appropriate differential diagnosis, and timely escalation of care when needed in that outpatient setting. So the patient was a 61-year-old female. Medical history was significant for type 2 diabetes. It was notably well controlled with a last A1C of 6.0. She also had hypertension, OSA, asthma, and a surgical history of adenoidectomy as a child. Both her mother and father had type 2 diabetes. Her mother had some hypertension. Her father also had some asthma, hypertension, obesity, some common themes within their family dynamic. Her social history was negative for most things. She was not a smoker, a drinker, and did not use any illicit drugs. So, most importantly, out of this to point out was that the patient did have several comorbidities that increased her risk for a more invasive infection. Diabetes, even when well controlled, is associated with impaired immune response and increased susceptibility to deep head and neck infections. Additionally, mastoiditis in adults tends to present atypically and is associated with higher complication rates compared to the pediatric population. Her chief complaint was painful swelling behind the right ear for 2 days. It was acute onset, very painful. She could not sleep at all the night prior. The postauricular swelling progressed rapidly over a short time frame. These are all red flag features for a serious infectious pathology. The pain had been progressively getting worse for the past 2 days, as well as that swelling behind her right ear. She described the pain as radiating into her neck and jaw and worsened by chewing. It was associated with headache and poor sleep. She also denied any fever, chills, nausea, vomiting. She did admit to a recent upper respiratory infection approximately 2 weeks ago that she actively was still coughing from at the visit. She denied any dental pain or recent trauma. The radiation of the pain into the jaw and neck, combined with pain on mastication, suggested a deeper infectious process rather than isolated cellulitis. Also importantly, the absence of fever does not exclude mastoiditis in adults, particularly in patients with diabetes or other chronic illnesses. That recent upper respiratory infection is also clinically significant, as mastoiditis typically develops as a complication of otis media following viral respiratory upper infections. The review of systems was notable for symptoms localized primarily to the head and neck without significant systemic complaints. She denied any fever, chills, night sweats, or weight loss. However, she did report very poor sleep because of how severe her pain was, which had been progressively worsening over the past 2 days. And she did admit she did not sleep at all the night prior, and her eyes were noticeably red and tired. From an ophthalmologic perspective, she did deny any vision change, double vision, sensitivity to light, or eye pain, making orbital involvement less likely at this time and more sleep deprivation, the reason for her reddened eyes. Ears, nose, and throat symptoms were the most significant. She reported painful swelling behind the right ear with radiation into the jaw and neck, which was exacerbated by chewing. She also endorsed associated headaches. Also important to note was that she denied autoria, hearing loss, tinnitus, vertigo, sore throat, dysphagia, dental pain, or any sinus pressure. The absence of dental systems helped lower suspicion for an ototogenic source, while the lack of autoria did not exclude mastoiditis, as adult presentations, once again, are often atypical. Cardiovascular and respiratory system reviews were largely unremarkable. She denied chest pain, palpitations, shortness of breath, wheezing, or chest tightness. She did note a lingering cough followed by an upper respiratory infection approximately 2 weeks prior, which is clinically relevant given the association between upper respiratory infections, ear infections, and secondary mastoid infections. The gastrointestinal and G genitourinary system was negative with no nausea, vomiting, abdominal pain, urinary symptoms, or bowel changes. Her musculoskeletal review revealed jaw and neck pain related specifically to mastification without any history of trauma or joint swelling. This helped differentiate from a TMJ type disorder. From a metabolic standpoint, the patient had a well-controlled type 2 diabetes, which still did increase her risk for invasive infections and atypical presentations. She denied any hyperglycemic symptoms. Neurologically, she reported headaches but denied any dizziness, focal weakness, any facial droop, confusion, seizures, or altered mental status. While all of these are definitely reassuring, the absence of neurological symptoms does not exclude an intracranial complication that could occur in the future. Psychiatrically, she denied anxiety or mood changes, though her sleep disturbances was related to her pain. Overall, the review of systems supported a localized but potentially serious head and neck process without any systemic inflammatory signs at the moment. Um, but an important reminder is that serious infections such as mastoiditis can present subtly in adults. On physical examination, the patient's vital signs were overall stable. Her blood pressure was 121 over 84, heart rate was mildly elevated at 92. And she was afebrile with a temperature of 97.9 degrees Fahrenheit. While the absence of fever may appear reassuring, current evidence emphasizes that adults with mastoiditis frequently lack systemic signs, particularly those with diabetes or other chronic conditions. Therefore, normal vital signs does not exclude serious infection. On general appearance, the patient was alert and oriented, but visibly uncomfortable due to the pain. She was afebrile and non-toxic appearing, without signs of acute systemic illness. Her discomfort was clearly localized rather than generalized, which raised concern for a focal, inflammatory, or infectious process rather than a viral or systemic condition. Ocular examination was unremarkable. Pupils were equal, round, reactive to light. Extraocular movements were intact, and there was no conjunctival infection or visual disturbances. These were all important findings because they're important in ruling out orally orbital or intracranial involvement, which can occasionally accompany advanced otogenic infections. The ears, nose, and throat examination revealed the most concerning findings. There was significant edema posterior to the right ear, extending beneath the ear and over the angle of the jaw. The right mastoid process was exquisitely tender to palpation, like even pinpoint touch with your fingertip. Um, Notably, there was no overlying erythema, warmth, fluctuance, or visible abscess. Pain was elicited with jaw opening and chewing, suggesting involvement of deeper structures. Oral examination showed no evidence of dental infections or abscess, helping to rule out a more dental process. The absence of auricular protrusion and skin changes does not necessarily rule out mastoiditis. Once again, as adults present often atypical, so you always want to think of what the worst possible differential could be and what you would need to do or monitor for that. Cardiovascular examination demonstrated a regular rate and rhythm without any murmurs, rubs, gallops. Peripheral pulses were intact. These findings were all reassuring and indicated hemodynamic stability at the time of evaluation and that she had no advanced systemic infections. Pulmonary examination was normal with clear breath sounds bilaterally and no evidence of any respiratory distress. This was important because one, she did still have that lingering cough from a recent upper respiratory infection. Um, but this also could indicate that some of her symptoms were not related to a pulmonary process. The abdomen exam was benign. The abdomen was soft, non-tender, non-distended. She denied any nausea or vomiting. She did note a lack of appetite due to the extremity of the pain. But this did help narrow the focus towards a more localized process rather than systemic. Her urinary system was deferred. There was no urinary symptoms that were even a differential of a UTI. Musculoskeletal examination showed a normal range of motion in all extremities. Pain was localized specifically to the right mastoid and jaw with movement, without joint swelling or deformity anywhere else in the body. This location further supported concern for a regional infectious process rather than a generalized musculoskeletal condition. From a metabolic standpoint, the patient has that well-controlled type 2 diabetes, and while there is no signs of acute hypo or hyperglycemia, diabetes is a known risk factor for more invasive and atypical infections, including mastoiditis in adults. This comorbidity significantly increased the index of suspicion, even though her physical exam was pretty stable. Neurologic examination was non-focal. The patient was alert and oriented with all intact cranial nerves, including, importantly though, facial nerve function. That was critical as facial nerve palsy can be an early sign of complicated mastoiditis. There was no altered mental status or any focal deficits. That was reassuring, but did not eliminate, once again, that possibility of an early intracranial extension. Um, Her psychiatric was appropriate. Her mood was definitely appropriate to the situation. And when the final evaluation and recommendations were made, she was very cooperative and demonstrated very good insight and judgment. She did, however, extreme very distressed and anxious because of how much pain she was in and just wanted to figure out what was causing this extreme pain. The differential diagnosis must be broad for this, given her age, diabetes, recent upper respiratory infection, and the location and severity of her symptoms. Acute mastoiditis is the primary and most concerning diagnosis and is what we necessarily need to take the interventions for. Adult mastoiditis once again presents atypically, frequently without fever or systemic symptoms, and may lack classic findings such as erythema or auricular displacement. Um, Bridwell 2024 emphasizes that mastoid tenderness and post-auricular pain alone should raise concern, particularly in high-risk populations such as a patient with diabetes. Palma et al. Further demonstrated that more than half of adult mastoiditis cases lacked classic pediatric features, contributing to diagnosis delay and higher complication rates. The next differential was a deep soft tissue infection, including the periauricular, postauricular, or parotid abscess. These are all also key considerations because these infections may present with localized swelling and pain without obvious fluctuance early in their course. Emergency medicine literature highlights that deep space infections in the head and neck may appear deceptively benign or initial on examination, but can progress rapidly if untreated, which is how her symptoms had been progressing up until this point. Necrotizing otis externa also was there, as it must be considered given to this patient's history of diabetes, while classically associated with severe autoalgia, granulation tissue in the external auditory canal, and autoria. Early disease once again may present subtly. This does carry a high risk of skull-based osteomyelitis and cranial neuropathies, so it should remain on the differential for diabetic patients with any autologic pain just to rule out. And that doesn't necessarily mean testing for it, but just the presence is a enough support to rule out other findings first. Reactive cervical or post-auricular lymphatitis is another possible etiology, particularly in her setting of an upper respiratory infection. However, lymphatitis typically presents with discrete mobile lymph nodes rather than diffuse mastoid tenderness and pain specifically with a movement. Um, the persistent pain and the mastoid tenderness make this diagnosis less likely. A TMJ disorder was also considered due to the jaw pain with mastication. However, the acute onset association with the postauricular swelling and focal mastoid tenderness are not really consistent with the primary TMJ pathology, because this is typically chronic and doesn't lack that inflammatory swelling. Finally, a head and neck malignancy should be considered in adult patients presenting with new unilateral head or neck masses or pain. Um, Although less likely in this acute presentation, malignancy shouldn't be excluded without imaging and should remain in the differential if symptoms do persist or fail to resolve and an infectious etiology is less likely. So, from a primary care perspective, this patient was assessed as having acute right postauricular pain and swelling with high concern for mastoiditis versus deep soft tissue infection. At the primary care level, the diagnosis is suspected acute mastoiditis or complicated otogenic infection rather than a definitive radiologic diagnosis. This is important to note because definite diagnosis requires advanced imaging and specialist evaluation, and that is outside of the scope of the outpatient setting. However, given the patient's focal mastoid tenderness, her pain with mastication, the upper respiratory, the diabetes, her overall presentation met criteria for a high-risk otologic infection. Um, Once again, all evidence points to adult mastoiditis frequently presenting without a fever or systemic symptoms, and delayed recognition is also associated with higher rates of intracranial complications. So, as a PCP, the priority is early recognition of a potentially serious condition, risk stratification, and timely escalation of care rather than attempting any outpatient management to help her today. So, the plan of care in the primary care setting is focused on recognition, stabilization, patient education, and urgent referral rather than definitive treatment. Based on national guidelines and current evidence, suspected mastoiditis requires urgent imaging and ENT consultation, which cannot be safely or effectively completed in the outpatient environment. The 2025 ACR appropriateness criteria recommends CT of the temporal bone with IV contrast as the initial imaging study when mastoiditis or complicated otis media is suspected. Given the risk of bone erosion, abscess formation, and intracranial spread, outpatient oral antibiotics were not initiated, as this could delay appropriate diagnosis and management. Bridwell et al. Emphasizes that empiric outpatient treatment may mask symptoms while allowing disease progression. The patient was therefore referred directly to the emergency department for advanced imaging, um, determination of IV versus oral antibiotic therapy, and otolaryngology consultation, or their decision that it is not mastoiditis, she does not need this consultation. And a direct provider to provider handoff was completed. She did call the Leominster ED herself to ensure that continuity of care was kept up and why she was referring this patient to the emergency room. The patient was hemodynamically stable and had no neurodeficits, so she safely proceeded to the emergency department via private vehicle. Of note, the office is about 3 minutes away from the emergency department. At this point, management was appropriately transitioned from primary care to adult care, emergency medicine, specialty services. However, for learning purposes, the pharmacological plan for mastoiditis, no empiric antibiotics were initiated in the primary care setting. This decision does align with those evidence-based guidelines recommending that antibiotic selection for suspected mastoiditis be guided by imaging findings, severity of disease, and specialists, particularly in adults. Initiating an oral antibiotic prior to imaging can mask clinical progression or delay definitive diagnosis, especially when that involvement or intracranial complications are present. Therefore, that was not appropriate, and she was deferred to the emergency department. Patient education focused on explaining the serious nature of the suspected diagnosis and the need for urgent evaluation despite the absence of fever or systemic symptoms. Also, education to reassure the patient that although it was a potentially serious differential diagnosis, all of her physical exam findings were reassuring that no serious systemic illness was yet involved. The patient was informed, however, that these differentials can progress rapidly and may involve the skull base or intracranial structures if not addressed or treated properly. Evidence demonstrates that complications occur in up to 25 to 30% of mastocytosis cases, including subperiosteal abscess, facial nerve palsy, meningitis, epidural abscess, and permanent hearing loss. The risk of delayed treatment were reviewed, including potential neurological complications following, the need for surgical intervention. The patient verbalized understanding of the urgency and was actually very thankful that we were being more cautious rather than like any watchful waiting and appreciated that. She did proceed to the emergency department right away for further evaluation and management because once again, she was in severe pain that like she could have honestly used a little bit of pain medication when she got to the emergency department as well. Following acute evaluation and management, the primary care's role would be to transition to care coordination and longitudinal follow-ups. So after a hospital discharge, primary care would follow up, and this is essential to review imaging findings, their hospital course, if they had an antibiotic completion, especially if they were discharged on antibiotics, um, or any ENT recommendations. Patients treated for mastocytitis or complicated otogenic infections should be monitored for reoccurrence, development of chronic mastocytitis, or any hearing changes. Audiologic evaluation may be indicated depending on the extent of the disease or treatment course. Ongoing management also includes optimization of chronic conditions such as diabetes, which is a known risk factor. For more severe and atypical infections, clear communication between primary care, ENT, and the patient is critical to reduce the risk of long-term complications and ensure appropriate full recovery. And that's all. And here is my email if anyone has any questions.